Section 4 of Gray's Anatomy, Part 3. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Julie van Mallegem. Anatomy of the Human Body, Part 3, by Henry Gray. Development of the Vascular System, Part 2. The valves of the heart. The atrioventricular valves are developed in relation to the atrial canal. By the upward expansion of the bases of the ventricles, the canal becomes invaginated into the ventricular cavities. The invaginated margin forms the rudiments of the lateral cusps of the atrioventricular valves. The medial or septal cusps of the valves are developed as downward prolongations of the septum intermedium. The aortic and pulmonary semilunar valves are formed from 4 endocardial thickenings, an anterior, a posterior, and 2 lateral, which appear at the proximal end of the truncus arteriosus. As the aortic septum grows downward, it divides each of the lateral thickenings into 2, thus giving rise to 6 thickenings, the rudiments of the semilunar valves, 3 at the aortic and 3 at the pulmonary orifice. Further development of the arteries. Recent observations show that practically none of the main vessels of the adult arise as such in the embryo. In the site of each vessel a capillary network forms, and by the enlargement of definite paths in this the larger arteries and veins are developed. The branches of the main arteries are not always simple modifications of the vessels of the capillary network, but may arise as new outgrowths from the enlarged stem. It has been seen that each primitive aorta consists of a ventral and a dorsal part, which are continuous through the first aortic arch. The dorsal aortae at first run backward, separately on either side of the notochord, but about the 3rd week they fuse from about the level of the 4th thoracic to that of the 4th lumbar segment to form a single trunk, the descending aorta. The first aortic arches run through the mandibular arches, and behind them 5 additional pairs are developed within the visceral arches, so that, in all, 6 pairs of aortic arches are formed. The first and second arches pass between the ventral and dorsal aortae, while the others arise at first by a common trunk from the truncus arteriosus, but end separately in the dorsal aortae. As the neck elongates, the ventral aortae are drawn out, and the 3rd and 4th arches arise directly from these vessels. In fishes, these arches persist, and give off branches to the gills, in which the blood is oxygenated. In mammals some of them remain as permanent structures, while others disappear or become obliterated. The anterior ventral aortae. These persist on both sides. The right forms a. the innominate artery, b. the right common and external carotid arteries. The left gives rise to a. the short portion of the aortic arch, which reaches from the origin of the innominate artery to that of the left common carotid artery, b. the left common and external carotid arteries. The aortic arches. The first and second arches disappear early, but the dorsal end of the second gives origin to the stapedial artery, a vessel which atrophies in man, but persists in some mammals. It passes through the ring of the stapes, and divides into supraorbital, infraorbital, and mandibular branches, which follow the 3 divisions of the trigeminal nerve. The infraorbital and mandibular arise from a common stem, the terminal part of which anastomoses with the external carotid. On the obliteration of the stapedial artery, this anastomosis enlarges and forms the internal maxillary artery, and the branches of the stapedial artery are now branches of this vessel. The common stem of the infraorbital and mandibular branches passes between the two roots of the auriculotemporal nerve and becomes the middle meningeal artery. The original supraorbital branch of the stapedial is represented by the orbital twigs of the middle meningeal. The third aortic arch constitutes the commencement of the internal carotid artery, and is, therefore, named the carotid arch. The fourth right arch forms the right subclavian as far as the origin of its internal mammary branch, while the fourth left arch constitutes the arch of the aorta between the origin of the left carotid artery and the termination of the ductus arteriosus. The fifth arch disappears on both sides. The sixth right arch disappears. The sixth left arch gives off the pulmonary arteries and forms the ductus arteriosus. This duct remains pervious during the whole of fetal life, but is obliterated a few days after birth. His showed that in the early embryo the right and left arches each gives a branch to the lungs, but that later both pulmonary arteries take origin from the left arch. The dorsal aortae persist and form the continuations of the internal carotid arteries. These arteries pass to the brain, and each divides into an anterior and a posterior branch, the former giving off the ophthalmic and the anterior and middle cerebral arteries, while the latter turns back and joins the cerebral part of the vertebral artery. Behind the third arch, the right dorsal aorta disappears as far as the point where the two dorsal aortae fuse to form the descending aorta. The part of the left dorsal aorta between the third and fourth arches disappears, while the remainder persists to form the descending part of the arch of the aorta. A constriction, the aortic isthmus, is sometimes seen in the aorta between the origin of the left subclavian and the attachment of the ductus arteriosus. Sometimes the right subclavian artery arises from the aortic arch distal to the origin of the left subclavian and passes upward and to the right behind the trachea and esophagus. This condition may be explained by the persistence of the right dorsal aorta and the obliteration of the fourth right arch. In birds, the fourth right arch forms the arch of the aorta. In reptiles, the fourth arch on both sides persists, and gives rise to the double aortic arch in these animals. The heart originally lies on the ventral aspect of the pharynx, immediately behind the stomacheum. With the elongation of the neck and the development of the lungs, it recedes within the thorax, and as a consequence, the anterior ventral aortae are drawn out, and the original position of the fourth and fifth arches is greatly modified. Thus, on the right side, the fourth recedes to the root of the neck, while on the left side it is withdrawn within the thorax. The recurrent nerves originally pass to the larynx under the sixth pair of arches, and are therefore pulled backward with the descent of these structures, so that in the adult the left nerve hooks around the ligamentum arteriosum. Owing to the disappearance of the fifth and sixth right arches, the right nerve hooks around that immediately above them, i.e., the commencement of the subclavian artery. Segmental arteries arise from the primitive dorsal aortae, and course between successive segments. The seventh segmental artery is of special interest, since it forms the lower end of the vertebral artery, and, when the forelimb bud appears, sends a branch to it, the subclavian artery. From the seventh segmental arteries, the entire left subclavian and the greater part of the right subclavian are formed. The second pair of segmental arteries accompany the hypoglossal nerves to the brain, and are named the hypoglossal arteries. Each sends forward a branch which forms the cerebral part of the vertebral artery and anastomoses with the posterior branch of the internal carotid. The two vertebrals unite on the ventral surface of the hindbrain to form the basilar artery. Later, the hypoglossal artery atrophies, and the vertebral is connected with the first segmental artery. The cervical part of the vertebral is developed from a longitudinal anastomosis between the first 7 segmental arteries, so that the 7th of these ultimately becomes the source of the artery. As a result of the growth of the upper limb, the subclavian artery increases greatly in size, and the vertebral then appears to spring from it. Recent observations show that several segmental arteries contribute branches to the upper limb bud and form in it a free capillary anastomosis. Of these branches, only one, viz., that derived from the 7th segmental artery, persists to form the subclavian artery. The subclavian artery is prolonged into the limb under the names of the axillary and brachial arteries, and these together constitute the arterial stem for the upper arm. The direct continuation of this stem in the forearm is a volar interosseous artery. A branch which accompanies the median nerve soon increases in size and forms the main vessel, median artery, of the forearm, while the volar interosseous diminishes. Later, the radial and ulnar arteries are developed as branches of the brachial part of the stem, and coincidentally with their enlargement the median artery recedes. Occasionally it persists as a vessel of some considerable size, and then accompanies the median nerve into the palm of the hand. The primary arterial stem for the lower limb is formed by the inferior gluteal sciatic artery, which accompanies the sciatic nerve along the posterior aspect of the thigh to the back of the knee, whence it is continued at peroneal artery. This arrangement exists in reptiles and amphibians. The femoral artery arises later as a branch of the common iliac, and passing down the front and medial side of the thigh to the bend of the knee, joins the inferior gluteal artery. The femoral quickly enlarges, and coincidentally with this, the part of the inferior gluteal immediately above the knee undergoes atrophy. The anterior and posterior tibial arteries are branches of the main arterial stem. Further development of the veins. The formation of the great veins of the embryo may be best considered by dividing them into 2 groups, visceral and parietal. The visceral veins. The visceral veins are the 2 vitelline or omphallomesenteric veins bringing the blood from the yolk sac, and the 2 umbilical veins returning the blood from the placenta. These 4 veins open close together into the sinus venosus. The vitelline veins run upward, at first in front, and subsequently on either side of the intestinal canal. They unite on the ventral aspect of the canal, and beyond this are connected to one another by 2 anastomotic branches, one on the dorsal and the other on the ventral aspect of the duodenal portion of the intestine, which is thus encircled by 2 venous rings. Into the middle or dorsal anastomosis the superior mesenteric vein opens. The portions of the veins above the upper ring become interrupted by the developing liver and broken up by it into a plexus of small capillary-like vessels termed sinusoids, Minot. The branches conveying the blood to this plexus are named the venae advenientes, and become the branches of the portal vein, while the vessels draining the plexus into the sinus venosus are termed the venae revihentes, and form the future hepatic veins. Ultimately, the left vena reverens no longer communicates directly with the sinus venosus, but opens into the right vena reverens. The persistent part of the upper venous ring, above the opening of the superior mesenteric vein, forms the trunk of the portal vein. The 2 umbilical veins fuse early to form a single trunk in the body stalk, but remain separate within the embryo, and pass forward to the sinus venosus in the side walls of the body. Like the vitelline veins, their direct connection with the sinus venosus becomes interrupted by the developing liver, and thus, at this stage, the whole of the blood from the yolk sac and placenta passes through the substance of the liver before it reaches the heart. The right umbilical and right vitelline veins shrivel and disappear. The left umbilical, on the other hand, becomes enlarged, and opens into the upper venous ring of the vitelline veins. With the atrophy of the yolk sac, the left vitelline vein also undergoes atrophy and disappears. Finally, a direct branch is established between this ring and the right hepatic vein. This branch is named the ductus venosus, and enlarging rapidly, it forms a wide channel through which most of the blood, returned from the placenta, is carried direct to the heart, without passing through the liver. A small proportion of the blood from the placenta is, however, conveyed from the left umbilical vein to the liver through the left vena advehens. The left umbilical vein and the ductus venosus undergo atrophy and obliteration after birth, and form respectively the ligamentum teres and ligamentum venosum of the liver. The parietal veins. The first indication of a parietal system consists in the appearance of two short transverse veins, the ducts of Cuvier, which open one on either side into the sinus venosus. Each of these ducts receives an ascending and descending vein. The ascending veins return the blood from the parietes of the trunk and from the Wolffian bodies, and are called cardial veins. The descending veins return the blood from the head, and are called primitive jugular veins. The blood from the lower limbs is collected by the right and left iliac and hypogastric veins, which in the earlier stages of development open into the corresponding right and left cardial veins. Later, a transverse branch, the left common iliac vein, is developed between the lower parts of the two cardial veins, and through this the blood is carried into the right cardinal vein. The portion of the left cardial vein below the left renal vein atrophies and disappears up to the point of entrance of the left spermatic vein. The portion above the left renal vein persists as a hemiazygous and accessory hemiazygous veins and the lower portion of the highest left intercostal vein. The right cardinal vein, which now receives the blood from both lower extremities, forms a large venous trunk along the posterior abdominal wall. Up to the level of the renal veins, it forms the lower part of the inferior vena cava. Above the level of the renal veins, the right cardinal vein persists as an azygous vein and receives the right intercostal veins, while the hemiazygous veins are brought into communication with it by the development of transverse branches in front of the vertebral column. Inferior vena cava. The development of the inferior vena cava is associated with the formation of two veins, the subcardinal veins. These lie parallel to and on the ventral aspect of the cardinal veins, and originate as longitudinal anastomosing channels which link up the tributaries from the mesentery to the cardinal veins. They communicate with the cardinal veins above and below, and also by a series of transverse branches. The two subcardinals are for a time connected with each other in front of the aorta by cross branches, but these disappear and are replaced by a single transverse channel at a level where the renal veins join the cardinals, and at the same level a cross-communication is established on either side between the cardinal and subcardinal. The portion of the left subcardinal behind this cross-communication disappears, while that in front, i.e. the pre-renal part, forms a connection with the ductus venosus at a point of opening of the hepatic veins, and rapidly enlarging, receives the blood from the post-renal part of the right cardinal through the cross-communication referred to. In this manner, a single trunk, the inferior vena cava, is formed, and consists of the proximal part of the ductus venosus, the pre-renal part of the right subcardinal vein, the postrenal part of the right cardinal vein, and the cross branch which joins these two veins. The left subcardinal disappears, except the part immediately in front of the renal vein, which is retained as a left suprarenal vein. The spermatic or ovarian vein opens into the postrenal of the corresponding cardinal vein. This portion of the right cardinal, as already explained, forms the lower part of the inferior vena cava, so that the right spermatic opens directly into that vessel. The postrenal segment of the left cardinal disappears, with the exception of the portion between the spermatic and renal vein, which is retained as a terminal part of the left spermatic vein. In consequence of the atrophy of the Wolffian bodies, the cardinal veins diminish in size. The primitive jugular veins, on the other hand, become enlarged, owing to the rapid development of the head and brain. They are further augmented by receiving the veins subclavian from the upper extremities, and so come to form the chief veins of the Cuvierian ducts. These ducts gradually assume an almost vertical position in consequence of the descent of the heart into the thorax. The right and left Cuvierian ducts are originally of the same diameter, and are frequently termed the right and left superior venae cavae. By the development of a transverse branch, the left innominate vein, between the two primitive jugular veins, the blood is carried across from the left to the right primitive jugular. The portion of the right primitive jugular vein between the left innominate and the azygous vein forms the upper part of the superior vena cava of the adult. The lower part of this vessel, i.e., below the entrance of the azygous vein, is formed by the right Cuvierian duct. Below the origin of the transverse branch, the left primitive jugular vein and left Cuvierian duct atrophy, the former constituting the upper part of the highest left intercostal vein, while the latter is represented by the ligament of the left vena cava, vestigial fold of Marshall, and the oblique vein of the left atrium, oblique vein of Marshall. Both right and left superior venae cavae are present in some animals, and are occasionally found in the adult human being. The oblique vein of the left atrium passes downward across the back of the left atrium to open into the coronary sinus, which, as already indicated, represents the persistent left horn of the sinus venosus. Venous sinuses of the dura mater. The primary arrangement for drainage of the capillaries of the head consists of a primary head vein, which starts in the region of the midbrain and runs caudalward along the side of the brain tube to terminate at the duct of Cuvier. The primary head vein drains three plexuses of capillaries, the anterior dural plexus, the middle dural plexus, and the posterior dural plexus. The growth of the cartilaginous capsule of the ear and the growth and alteration in form of the brain bring about changes in this primary arrangement. Owing to the growth of the otic capsule and middle ear, the course of the primary head vein becomes unfavorable, and a segment of it becomes obliterated. To make the necessary adjustment, an anastomosis is established above the otic capsule, and the middle plexus drains into the posterior plexus. Then the anterior plexus fuses with the middle plexus, and drains through it and the newly established channel dorsal to the otic capsule. All that remains of the primary head vein is a cardinal portion or internal jugular, and the part in the region of the trigeminal nerve, which may be called the cavernous sinus. Into it drain the orbital veins. The drainage from the cavernous sinus is now upward through the original trunk of the middle plexus, which is now the superior petrosal sinus, into the newly established dorsal channel. This dorsal channel is a transverse sinus. The inferior petrosal sinus appears later. From the anterior plexus a sagittal plexus extends forward, from which develops the superior sagittal sinus. The straight sinus is formed in the ventral part of the sagittal plexus. As the hemispheres extend backward, these sinuses elongate by incorporating the more caudal loops of the plexus. The anterior part of the sinus is completed first. The external jugular vein at first drains the region behind the ear, posterior auricular, and enters the primitive jugular as a lateral tributary. A group of veins from the face and lingual region converge to form a common vein, the linguofacial, which also terminates in the primitive jugular. Later, cross communication developed between the external jugular and the linguofacial, with the result that a posterior group of facial veins is transferred to the external jugular. End of Section 4.